And now let's hear Professor Gili Kenet, who is the director of the National Hemophilia Center and Thrombosis Institute and chair of the Amalia Biron Research Institute of Thrombosis and Hemostasis at Sheba Medical Center. This was established by Uri. And she will talk about emerging options for hemophilia treatment in the new era. Please.
Thank you, Nili. I thank the organizers for the opportunity to honor Uri's legacy and memory here again. And I'm going to talk to you about hemophilia and the changing paradigm of treatment in the recent years. So these are my disclosures. You've already heard a little about hemophilia, the bleeding infant that shouldn't be circumcised, the hemarthrosis, the life-threatening bleeds that Professor Solomon just mentioned. Hemophilia used to be a devastating disease. Patient with deficient coagulation factor, either factor 8, whose deficiency is called hemophilia A, or factor 9, whose deficiency is called hemophilia B, would present at infancy and then with repeated joint bleeds and life-threatening bleeding episodes. Hemophilia used to be treated by blood products and then by commercially produced replacement products. When I started hemophilia practice over 20 years ago, you needn't be very smart to treat hemophilia. You just give whatever is missing. Hemophilia A, you provide the patient with factor 8. Hemophilia B, you provide the patient with factor 9. Your job is done. However, this paradigm of treatment has changed now from replacement products aiming at supportive care of the bleeding patients to zero infection, because along with the blood-borne products, HIV and hepatitis C were transferred to patients years ago, and then to zero bleeds, zero inhibitors of care, non-replacement products, and functional care, where we aim that hemophilia patients would live a normal life and behave normally, normal physical activity. They already have normal life expectancy. And the most exciting thing, a cure is now available, namely gene therapy. So this is the Israeli National Hemophilia Center. We now treat over 700 patients with hemophilia A and B, along with other severe bleeding disorders. The hallmark of hemophilia therapy has always been prophylaxis. And prophylaxis, of course, is tailored by the patient, his way of life, whether he is very active or not, the number of target joints, joints that have bled before and are more susceptible to more bleeding, and the trough factor level that you want to introduce in order to protect him. Nowadays, there is an increase in life of hemophilia A patients. The longevity is similar to the population. And we are now facing a whole new world. We cope with the spectrum of cardiovascular disorder. We cope with cancer. We become primary care physicians of disorders that are not necessarily related to hemophilia. These are our challenges today. The challenges of intravenous replacement therapy are very obvious. First of all, you have to deal with venous access issues. And this happens in the very young, and it also happens with the very old. Second, if you provide replacement therapy, if you provide coagulation products that were not produced by the body, you may face the issue of inhibitors. So how do we deal with that? First of all, we now have better replacement. We have extended half-life products. Then we have products that are factor mimetics. For example, we have bypass products who mimic the action of factor 8, such as emicizumab, a bispecific antibody that binds to factor 9 and 10, and therefore it eliminates the need for factor 8 completely. Even if there are inhibitors to factor 8, you don't care. You can still treat. Then there are the rebalancing products that Professor Solomon has already mentioned. Why rebalancing? Because instead of targeting the deficiency, you just reduce the brakes of the coagulation system. You deal with the natural anticoagulants. Once you reduce them, you can provide sufficient although not normal hemostasis. And of course, there is disease correction by ultimate gene therapy. I have marked here with yellow and with orange the products that are currently available at the National Hemophilia Center that has always been in the forefront of hemophilia research worldwide. Since 2019, emicizumab, the bispecific antibody targeting coagulation factor 9 and 10, has been approved in the Israeli health basket for treatment of patients with hemophilia A with and without factor VIII inhibitors. The commercially sponsored studies, large multicenter international studies, have taught us that this is a safe and efficacious drug. There is a large percentage of patients with zero treated bleed that even increases with time, and 95% of the target joint, the susceptible joints, were cleared throughout the study period. However, we said that the hallmark of hemophilia care is prophylaxis, and prophylaxis begins in infants. I'm a pediatrician, so this is my arena. If you deal with prophylaxis and hemophilia and you approach PubMed, you will find over 400 pages and almost 5,000 references. If you limit that to infant, only 58 pages and about 600 references. If you add emicizumab, which is this novel drug, only 2 pages, only 16 results, and only 4 deal with PAPs, previously untreated patients. So what is our approach today? We have more options. When parents come to my room with an infant and we discuss the options to start prophylaxis, it is always a shared decision-making process. We should decide when to start. We should decide which product is better, whether to stick to the traditional factor VIII that requires intravenous access or to go for the novel drug that is subcutaneously administered. Very nice, but we don't have long-term results yet, and some fear from complications. There are several novel studies that would give us the answer within the next few years, comparing emicizumab treatment in very young children with the treatment of not standard but extended half-life coagulation products. What is our experience? This is our pediatric paper published 2 years ago in the British Journal of Hematology. We studied a group of 40 children and found out that about 50% of them had zero bleeds under emicizumab prophylaxis, and most children that bled were between the ages of 1 and 12, which actually makes sense because most bleeding were trauma-related. If we further look into our Israeli cohort, we see that while children mostly bleed due to trauma, adults may bleed spontaneously, especially if they have target joints. And we see that when we study emicizumab plasma levels and when we study thrombin generation as a marker of hemostasis, the levels increase following a loading period and are sustained through a very long follow-up. A population of special interest would be the population of older patients with cardiovascular risk factors. We followed these patients for a long period, and we found that there is a reduction of bleeding episodes as well as reduction of painkiller consumption. However, some of them did suffer mucocutaneous bleeds, especially if they were treated with antiplatelet drugs concomitantly because of cardiovascular risk factors. What about adverse events? Anti-drug antibodies may develop in 1% of patients. There was one sad death in a small infant, 5 months old, who was ill with other comorbidities, and he had a central venous line, a thrombosis, a clot at the tip of the catheter, which is not uncommon even in cases with hemophilia, and eventually he died of retroperitoneal bleed unrelated to the emicizumab treatment. Let's look a little into the option of rebalancing agents. The most famous now is the trial that is still ongoing, the phase 3 trial of fitusiran. Fitusiran is a small interference RNA that targets antithrombin, a very strong coagulation inhibitor in the liver. We know that patients with antithrombin deficiency present early in life with arterial and venous thrombosis. So in a phase 3 study, multi-center international, patients were given fitusiran every month or every 2 months. A massive reduction of bleed was noted for patients with hemophilia A and B with or without inhibitors, as well as a reduction of antithrombin level. And as expected, this was accompanied by side effect of thrombosis that needed modulation of the protocol. Another potential target for the rebalancing therapies is anti-TFPI. Tissue factor pathway inhibitor is a natural inhibiting protein that inhibits the activation of coagulation cascade. So if we inhibit TFPI, maybe we produce better hemostasis. Well, studies are still ongoing, and some companies had to abort these studies because of cases of arterial thrombosis. Finally, last but not least, gene therapy. You all know that hemophilia is a genetic disease. It's a single gene disorder, and luckily for us, we do not need to increase the coagulant factor level to 100% in order to achieve hemostasis. Even a small increase tremendously improves patient bleeding tendency and quality of life. So gene is delivered by viruses. The most common vector for viral delivery of hemophilia gene is currently the adeno-associated virus. There are many trials. Some of them took part in our center, and recently there was a New England publication of the phase 2 trial of one of these drugs. In the US, 2 drugs are currently registered. One is a product for treatment of hemophilia B, and the cost for a single dose that is supposed to clear hemophilia and treat the patient for life is $3.5 million. The other is for hemophilia A that was recently registered. There are still many obstacles to gene therapy. For example, the drug is given, the plasmid that has the gene on, is given via a virus. So if you have pre-existing antibodies to that simple virus, you cannot take part in this study. Pediatric patients are not allowed to take part in gene therapy. Their liver is still ongoing, and no one knows what is the long-term results. During these gene therapy trials, because the genes are directed to the liver where clotting factors are produced, there are issues of safety, transaminase elevation that needs to be treated, sometimes by immunosuppression. Extension of therapy to patients with inhibitor is dealt with, but no one is doing it yet. And last, we don't know how long the impact of gene therapy persists. We now have over 10 years experience in hemophilia B, and we have about 5-year experience with hemophilia A trials. But if the factor level starts to decline, then afterwards you end up with a situation that is similar to milder hemophilia, which all the current drugs in the market can now achieve without gene therapy. And you cannot undergo AAV-delivered gene therapy again because you already have antibodies to that AAV. So you should go with modes that are less safe today, with lentiviruses, with CRISPR that cuts and repairs the DNA. So we do not have enough experience with that today. And there are things to look for, and they haven't even addressed the elephant in the room, which is the horrible price of this event. To summarize, treatment landscape for hemophilia A and B is rapidly evolving nowadays, and it's important for us healthcare professionals to understand the advantages and disadvantages of the novel factor and non-factor replacement therapies. Investigational therapies that aim to restore the hemostatic balance have been shown to reduce bleeding rates in patients with hemophilia A and B with and without inhibitors. And as I mentioned before, there are 2 products that were already approved as drugs for curing hemophilia patients by the US FDA and by the European community. You probably want to ask me what would be the ultimate treatment for hemophilia, because we are getting there, but we are not quite there today. So I assume that the ultimate drug would be a drug that is long, hypothetically lifelong acting. It would be applied orally, we're not there, or subcutaneously. We do have some drugs like that already. It would be able to be given to a broad patients population, including the previously untreated infants, including the elderly with comorbidities. It would be easily monitored. It would have minimal adverse events. It would be effective, safe, well tolerated, and available worldwide for a very reasonable price. Am I dreaming? New therapies require new attitude. And now we are coping sometimes with treatment burden, as I mentioned, the thrombotic effects and the liver enzyme elevation, etc., rather than with the disease burden itself. And with that thought, I would like to finish, and thank you all for your attention.
Thank you very much. Can you tell us how did more than 100 years ago Rasputin, who was not a doctor at all, did help the son of the Tsar in this disease?
Okay, help is relative. First of all, we know that emotional stress may increase bleeding tendency in some patients. So hypnosis is not bad, but hypnosis is not as curative as non-replacement therapy that we have nowadays or gene therapy. And the proof for that, if you're familiar with the history and with the history of art, is whenever the young Tsar was shown on picture, was drawn, he went on like this. You know why? First of all, it's military, it's respect. Second, he had repeated knee hemorrhagosis that shortened his tendons. He was unable to straighten that foot. So Rasputin was no miracle worker. Maybe he helped a little, but now we hope that we can cure it.